In the 1930s, surgeons operating on women with irregular menstrual cycles noticed something highly specific: ovaries covered in what looked like multiple small, fluid-filled sacs. They named the condition based entirely on this visual finding. But that localized, reproductive-centric diagnosis is scientifically inaccurate. The sacs covering the ovaries are not actual pathological cysts. At the microscopic level, we see a healthy ovarian follicle. As it attempts to mature, it abruptly stops developing. That arrested follicle is what early doctors mistook for a cyst. Framing this as an anatomical problem with the ovaries obscures the true pathology. The ovaries are simply the downstream victims of a systemic breakdown happening elsewhere in the body. Relying on this outdated model has severe clinical consequences. Up to 70% of affected individuals remain undiagnosed or face significant delays in getting answers. The established label, Polycystic Ovary Syndrome, or PCOS, forces doctors and patients to center their attention on a single organ, creating endless confusion. This graphic from the 2023 International Guidelines illustrates how focusing on the polycystic aspect contributes to fragmented care, isolating systems that are actually deeply connected. The medical community is now shifting to a precise definition: Polyendocrine Metabolic Ovarian Syndrome, or PMOS. This defines the condition accurately as a complex, interacting network of metabolic and endocrine dysfunctions. Discarding the old name is the necessary first step to removing patient stigma and ending a fractured, reproductive-only approach to medical care. The 2023 International Evidence-Based Guidelines now advise against relying heavily on pelvic ultrasounds for diagnosing adults. Because arrested follicles are highly common in younger patient populations, evaluating ultrasound morphology frequently leads to overdiagnosis. Instead, clinicians are turning to anti-Müllerian hormone, or AMH. This biochemical marker serves as a highly reliable primary indicator for defining polycystic ovarian morphology. On the left, we see a subjective ultrasound scan. On the right, an AMH biochemical assay. Moving to blood tests provides the objective precision required for accurate detection. While AMH is a powerful tool, relying on any single biomarker is insufficient for a condition as heterogeneous as PMOS. We build a complete multi-marker diagnostic matrix by placing AMH at the center and introducing orbital data nodes for metabolic markers like adiponectin and C-peptide. Integrating these metabolic markers allows physicians to map out the specific insulin-driven dysfunctions unique to each patient's physiology. We then expand the matrix by adding a node for the inflammatory marker HSCRP. Quantifying inflammatory status completes the foundational diagnostic picture. It provides the exact data needed to distinguish between different severities of the syndrome. Emerging diagnostic models for 2026 deploy artificial intelligence to instantly synthesize these hormonal, metabolic, and inflammatory inputs into a cohesive profile. Transitioning from subjective visual confirmation to a comprehensive multi-marker biochemical framework allows us to isolate specific patient phenotypes and eliminate misdiagnosis. Now that we can accurately detect the disease, we must trace the foundational mechanism driving it: intrinsic insulin resistance. In this abstract endocrine feedback loop, a metabolic blockage at the liver and muscle tissue represents insulin resistance. This blockage triggers an immediate alert signal to the pancreas. The pancreas reacts with a systemic overcompensatory response, flooding the body with excess insulin, a state known as hyperinsulinemia. That massive wave of excess insulin flows directly to the ovaries, where it heavily stimulates an inner ring of tissue called the theca cells. When excess insulin overstimulates these theca cells, it triggers an intense biochemical reaction. They respond by emitting a severe surge of androgens into the surrounding biological system. This resulting hyperandrogenism is the hallmark hormonal imbalance of the condition. The excess insulin acts as the primary amplifier for androgen production. As we trace the path of these excess androgens, we see them physically intercept and surround a nearby maturing follicle. The high androgen concentration creates a toxic microenvironment. It locks the follicle in place, preventing it from fully maturing. This microscopic ovulatory arrest creates the exact structures that appear as fluid-filled cysts on a standard ultrasound. What looks like an isolated failure of the ovaries is actually a downstream consequence of upstream metabolic and endocrine imbalances. Effective clinical management demands that we stop masking symptoms and directly target these specific physiological bottlenecks. We start at the source. Applying metformin directly to the liver and muscle nodes addresses the root metabolic blockage. Metformin mitigates insulin resistance, which immediately lowers systemic insulin levels and dampens the overproduction of androgens at the ovary. Next, we apply combined oral contraceptives, or COCs, to neutralize the remaining free-floating androgens in the system. COCs act as a highly effective first-line therapy to directly suppress systemic androgen excess. They also serve a critical secondary function by regulating the endometrium to prevent long-term complications. Finally, for patients trying to conceive, letrozole is applied at the ovarian node to break the androgen blockade. Letrozole is an evidence-based aromatase inhibitor specifically utilized to disrupt ovulatory arrest and successfully induce ovulation. These established pharmacological treatments stand in sharp contrast to experimental interventions like inositol. This chart details evidence grading from the international guidelines. Section 5.8 clearly highlights that evidence regarding inositol's effect on clinical pregnancy remains uncertain. Similarly, Row 5.9.1 demonstrates that the use of anti-obesity agents for reproductive outcomes is currently restricted strictly to research settings. Effectively treating PCOS requires strict adherence to this evidence-based grading, mapping proven pharmacological tools directly to the pathological bottlenecks they are designed to clear. The ultimate goal of this clinical framework extends beyond immediate symptom management. It is designed to protect the patient's long-term health trajectory. Left untreated, the metabolic drivers of PMOS operate as severe, risk-enhancing factors for lifelong cardiovascular disease and endometrial cancer. This narrowing vessel vividly illustrates the silent, progressive cardiovascular threat that is driven by sustained metabolic dysfunction over decades. Accurate phenotype classification using AMH and multi-marker panels is the most reliable method to identify these specific vulnerabilities and disrupt the long-term risks early. A precise diagnostic matrix defines the exact nature of the endocrine failure, while targeted treatment protocols map directly to the source of the dysfunction. The transition from Polycystic Ovary Syndrome to Polyendocrine Metabolic Ovarian Syndrome is a structural shift towards precision medicine that restores endocrine balance and protects patient outcomes for life.